name is Carlos Collet. I'm an interventional cardiologist from the Cardiovascular Center OLV-Aalst in Belgium. And I'm really happy to be here with you in the 7th MedicReS Congress of Cardiology. The topic of today is physiological assessment of coronary artery disease. And for this, the organization of the meeting has requested me to discuss about CFR, FFR, IFR, FFR-CT, and shear stress. And we will try to understand in the following slides what each of these acronyms actually means for our patients. These are my disclosures. So the field of interventional cardiology actually started around 40 years ago. This is a landmark paper published by Andreas Grunzig in '79, showing the first balloon angioplasty for a patient with angina pectoris without the need of surgery. And this indeed changed the complete landscape of cardiology, and a new field was born that was interventional cardiology. If we look at this particular paper, again, late 70s, we found this illustration. And from the very beginning, Andreas Grunzig and his team were already aware of the importance of coronary physiology to understand better the coronary pathology. You see these two important graphs. In the left side of your screen, you will see a very nice diagram that is percent diameter stenosis in the y-axis and mean pressure gradient in the y-axis. And he reported how this improved after balloon angioplasty. And if you look now at the long pressure tracings that you have on the right side of your screen, you will see that already in '79, they were performing pullbacks of pressure inside the coronary artery. So we're not talking of anything new. This was actually born within interventional cardiology. A few years before, Lance Gould in the United States performed this landmark study showing in dogs how there is a correlation between the diameter stenosis in a coronary artery and the coronary flow reserve. Coronary flow reserve is defined as the number of times that the flow can increase compared to the resting conditions. In other words, hyperemic flow divided by resting flow. And he observed that when the diameter of stenosis was around 50%, there was a decide based on the angiography whether the patient needs to be revascularized. I would say that 30, 40 years later, our team in Aalst, led by Gabor Toth, published this important paper showing that this 50% diameter stenosis was extremely variable when you compare with fractional flow reserve, which became the gold standard to assess epicardial lesion significance. And you see here a scatter in the complete plot showing how lesions with diameter stenosis more than 50% can have non-significant hemodynamic impact, whether lesions...
Sorry, can you start this page again? Because your sound is broken, we can record you.
Okay.
Thank you very much. No, only this page. Yep. Thank you very much.
Okay, so the concept of coronary flow reserve was actually developed a few years before Andreas Grunzig by Lance Gould in the United States. And this work showed how coronary flow reserve, which is a metric that depicts how many times the coronary flow can be increased during hyperemic conditions, starts to decrease after a threshold of 50% diameter stenosis. And this is the base why today we use 50% diameter stenosis to decide whether the patient needs to be revascularized. 35 years later came Gabor Toth from our institution and performed this analysis, now looking at diameter stenosis in your y-axis and FFR in your x-axis. And he actually showed that there is a scatter and we are not able to identify the lesions that are hemodynamically significant based on FFR just by looking at diameter stenosis alone. So these are very important studies showing that physiology actually is required to understand the physiological impact of a lesion in the coronary artery. Then came Morton Kern, also from the US, and using Doppler, he established the cutoff for coronary flow reserve as a conceptual framework of coronary physiology. What you see in the screen is actually a Doppler measurement inside a coronary artery in resting conditions and in hyperemia. In resting conditions, you will see that the flow velocity or the flow of that vessel is small, is low, but after we induce hyperemia, in this case with adenosine, and you will see it now on the screen, you will see an immediate increase in the flow of that particular coronary vessel. And this actually means that the vessel is able to accommodate an increasing flow, and thus this patient will have no angina. This was already presented by Andreas Grunzig as defined in the first slide. However, what were the limitations in that time? The catheters were big. There were no hyperemia. All this was resting conditions, resting parameters. And instead of pressure ratios that we're going to see in the FFR, he used delta pressure across the lesion. The pioneering work of Nico Pels and Bernard de Bruyn actually looking at the relationship between flow and pressure is extremely important, because flow is very difficult to measure in the catheterization laboratory. To have a good flow signal, as we show in the previous slide, is extremely difficult. However, pressure is pretty practical and pretty easy to measure. So the work of Nico Pels, the experimental basis to assess the correlation with flow and pressure, actually show a linear relationship between flow and pressure during hyperemia. And this is why we are able to look at pressure as a surrogate of flow to decide whether the patient needs to be treated or not. The validation of Nico Pels was done in animals in the '93, and last year we published that this is also true in humans, showing a linear correlation between flow and pressure, again also in humans. So after all this work, all resumes to this equation. What is FFR? Actually, FFR is the PD, or the pressure measured inside the coronary distal, divided by PA, that is the pressure measured in the aorta. Therefore, FFR is a ratio of intracoronary pressure divided by aortic pressure, and this is measured during hyperemia. FFR was initially validated against non-invasive tests. And this was a very elegant study where the patients underwent non-invasive tests, then revascularization, and then again non-invasive tests. And what was considered the true gold standard was the fact that the patient had a positive exercise test, perfusion, or echocardiography with dobutamine, and then normalized after vascularization. And based on this true gold standard was FFR validated. Later on, Emanuele Barbato, also from our institution, described that patients that are not revascularized have a higher chance of having an adverse event according to the FFR value. In other words, FFR as a continuous metric, in this slide from 0.4 to 0.9, the higher the FFR, the lower the FFR, the higher the increase in the rate of major adverse cardiac events. Later on came a few iterations of FFR, now looking at non-hyperamic pressure ratios. So we went back 40 years to the work of Grunzig and tried to eliminate hyperemia. And this is how the non-hyperamic pressure ratios were born. The most famous of these ratios is IFR, which actually is the same formula, PD divided by PA, in the wave-free period, which is a period that is thought to be located in the mid-diastole, and this is actually measured without the need of hyperemia. There were two big randomized clinical trials, the DEFINE, FLAIR, and the SWEETHEART, showing that IFR was non-inferior to FFR what concerns the occurrence of clinical events. However, we have to look these two trials very carefully, because in these trials, by protocol, if the angiographic stenosis was more than 70% visually, there was no need for pressure wire. So all the patients that had severe lesions were just stented. They didn't have any FFR or IFR measure. And how many were these patients? We're talking about 46% of the complete population was stented without these measures being performed. Therefore, we have to be very careful, and it's a word of caution, to use these non-hyperemic ratios in severe lesions. We have actually no data to validate this approach. There is a plethora of non-hyperemic pressure ratios. After IFR came DPR, then came RFR, and so forward. Now every company has a non-hyperemic pressure ratios, and these ratios are actually useful in cases when you want to avoid the use of adenosine of papaverine or inducing hyperemia. So sometimes you can use these pressure ratios to help you, especially in particular cases, to avoid induction of hyperemia. FFR also got non-invasive. There is FFR derived now from CT, from coronary computed tomography, and now there is also several softwares that are able to calculate the FFR coming from conventional angiography. If we go to the FFR validation pathway, and this was the first study called the DEFER, that actually look at what happened when you defer a patient of stenting based on your FFR value. And we'll be looking at the blue line in the left side of this Kaplan-Meier curve, showing that when a patient has a non-significant lesion, at this time defined as an FFR more than 75, and you defer stenting, you actually get pretty reasonable, pretty good clinical results over 2 years of follow-up. Now, if we go to the 15 years of follow-up of the same cohort of patients, you see that the patients with normal FFR by the time that they were catheterized with an FFR more than 78 did far better than the patients that had an FFR below 0.75 or the ones that have more than 75 but an angiographic lesion and nevertheless were stented. The second group of studies were the FAME studies, FAME1, FAME2, and next year we'll see the results of FAME3. Actually, in FAME1 was a randomization between an FFR-guided PCI versus angiography-guided PCI, and this actually proved that using FFR to help you in the decision-making concerning the need of PCI over-vascularization is associated with a reduction in death and MI in this group of patients. If we look now at FAME2 tried a different hypothesis. The hypothesis of FAME2 is what happens if we identify the patients that have severe coronary stenosis based on FFR, and then we randomize these patients to two groups. One group is revascularization with PCI, and the other group is medical therapy alone. And you will see here a 64% reduction in the cumulative incidence of adverse events with PCI compared to medical therapy. Therefore, selecting your patients based on FFR improve death, MI, among other things. When we look now in detail at FAME2, and now I'm going to focus on spontaneous MI, which is actually one of the biggest drivers of the benefit of PCI in this subset of patients, we will see that the curve starts to diverge around 2 to 3 years after the measurement of your FFR or your PCI, and you will see here how the patients that actually got a PCI did far better than the patients that were managed only by medical therapy. And we're talking about a 40% reduction in the incidence of myocardial infarction. Now, if you look at the right side of the slide, which is a very important message, is the fact that most of the benefit that we observed in FAME2 were in patients that were completely asymptomatic. This means silence ischemia, patients with positive FFR, without symptoms. These are the patients that actually did far better with PCI compared to medical therapy alone. After these studies, we have let's say the big elephant in the room, which is the ischemia trial that was published earlier this year. And this trial actually showed that there is no difference in a composite endpoint of cardiovascular death, myocardial infarction, revascularization, hospitalization for unstable angina, and new onset of heart failure between an invasive and a conservative strategy. And why, if you look at the curve, there is something very interesting that happened in this study. You will see that the conservative group of the medical arm of the study was the blue curve, whereas the red line is the patients that underwent invasive strategy with or without revascularization. That could be either CABG or PCI. You'll see that there is an early hazard of the invasive strategy. This is mainly related to the procedure. But then look what happens. Around 2 years after the randomizations, these curves cross each other, and then you start to see a benefit of the invasive strategy. If we look this in a different way, now with a bar chart, you will see that the rates of the cumulative endpoint at 5 years were less with the invasive strategy, numerically less, compared to the conservative strategy. The ischemia was reported as a negative study, but we see ischemia in a different way. So one of the things that we did to tackle ischemia and the fact that this curve crossed early in the early follow-up is that we reverse engineers the curve to have an idea of what really happened in the trial. Once we have the times to event data, we created this curve. And these curves are extremely interesting to look at. You will see in your y-axis the risk, your hazard ratio, and in your x-axis the time. And this is what happened in ischemia. Everything that is above this blue line means that the conservative strategy is better. And everything that is below means that your invasive strategy is better. You will see immediately that there is an early hazard of the intervention. Why? Because there are quite some periprocedural myocardial infarctions that, of course, do not occur if the patient do not undergo any invasive procedure. But the most interesting part of this curve is this one. Look what happened after approximately 1 year after the randomization. There is a clear reduction in the occurrence of myocardial infarction in patients that undergo an invasive strategy. Why is this? And this is a paper recently published from Shipper Bangalore showing that with the advance of the new technologies like drug-eluting stent with very thin struts, we were able to improve the mid and long-term outcome of these patients. And what we're looking in the screen is the risk of a spontaneous myocardial infarction in patients treated first in the early 2000s with balloon, then from 2000 to 2010 with thick first-generation stents and some bare metal stents. But look what happened when you use the new technologies that we have at our disposal at this moment. You clearly see that there is a reduction in the incidence of a spontaneous myocardial infarction, and it's exactly what ischemia showed. But if we take one step back and we say, okay, ischemia is the cornerstone of the evaluation of patients with suspected coronary artery disease, we think that a reversible myocardial ischemia is associated with poor outcome, and therefore looking for ischemia should be the goal of the diagnosis and then the target of treatment. And this hypothesis, I think, should be revised. And we have a working hypothesis that we might be barking at the wrong tree, and ischemia might just be a bystander of what is actually behind it, which is an hemodynamic significant plaque. So if you look at this picture, you will say, yeah, this is ischemia is a marker of abnormal physical forces taking place at the level of epicardial vessels. You'll say yes, but the problem of this car is not the smoke coming out of the back of the car, but it's the engine. So we are focusing on ischemia, we're focusing on the smoke, maybe we should look at the motor. And this is what we're gonna do in the next slides. So maybe it's not about ischemia, maybe we have to go back to the concept of plaque vulnerability, of plaque fatigue, plaque stress, and we have pretty nice tools to look at this in a wall shear stress to understand the pressure gradients. And again, the same word that was used by Grunsik 40 years ago comes again to try to understand why these plaques actually are progress and rupture. And the plaques rupture when the physical forces that are exerted in that plaque exceed the material strength. And then, of course, when this plaque ruptures, you create a myocardial infarction. And look at this patient. This is a patient that came to our lab in 2017. He has a moderate lesion in this right coronary artery. You'll see here in this segment a 30 to 40% stenosis. And we decided to treat him medically at that moment. Look, he came 2 years later with a clear occlusion of that coronary artery, now with a clear ST elevation myocardial infarction. And what happened? So we're trying to understand how to better identify these patients. What I'm going to show you now is a prototype that we're working with that is a tool that, using angiography and QCA, is able to provide us with the values of shear stress to understand whether these lesions are different from the ones that actually do not rupture. And what we have found is that there is a metric called the topological shear stress index, or TSVI, that actually measures the wall shear stress vector during contraction and expansion of the coronary artery. That actually is an excellent predictor of myocardial infarction, and you will see here depicted by a very high area under the curve for TSVI of 0.77 compared to traditional metric of time average wall shear stress that indeed have a predicted capacity, but this is not enough to help us in decision making. Further on is not only about hemodynamics, it's also about plaque composition. And this is a very elegant study coming from Korea showing that we can also identify plaques that are prone to rupture and cause subsequent acute coronary syndromes, not only by looking at the rheological factors, but also looking at the biology of the plaque. In this case, using computed tomography, we're able to identify this type of plaques. This is the lumen over here, and this is a huge positive remodel plaque with a huge necrotic component in the middle that are actually associated with acute coronary syndromes. Moreover, when we look at the computational fluid dynamics that are performed within the computed tomography three-dimensional reconstructions, we see that there are several parameters that can be extracted. And in this particular study, there were adverse hemodynamic characteristics identified, such as the pressure gradient and high wall shear stress and high axial plaque stress. And all of these metrics actually help predicting the occurrence of an acute coronary syndrome. FFR-CT is indeed a tool that helps us to see how the FFR behave across the coronary vessel. This is what we call the functional endotypes of coronary artery disease, from diffuse disease in the left side of your screen to focal disease on the right side of your screen. And these models are color-coded based on your FFR-CT values, meaning that when you have very low FFR values, these vessels are color-coded in red, whereas the FFR is normal, they're color-coded in blue. But more important than actually looking at your distal FFR value is to see this pullback curve. You can see here on the left side how it's a diffuse pressure loss across the coronary vessel with maybe a small focal step up here. You see more or less the same in this second pattern. And when you look to the right side of your screen, you clearly see focal stenosis. So in this focal stenosis, the amount of forces generated by these pressure gradients are actually something that we think is one of the drivers of plaque destabilization and the occurrence of acute coronary syndromes. And this could be a very favorable endotype for PCI. In contrast, if you think about doing PCI in case of diffuse disease, you might think that twice, and we're going to show that in the next few slides. So now the concept that comes into the main arena of our thinking is, should we treat focal, or how to identify focal lesions and how to identify diffuse disease, and should we treat these two disease endotypes in a different way? And I'm going to show you one case or two cases to understand a bit the concept behind. These are two cases with a positive FFR based on the European guidelines, but when you look at the pullback curve, again, this is invasive data with a motorized device pulling back an FFR pressure wire and showing that actually there is a focal functional disease on the left side of your screen that is actually depicted by this pressure drop in the mid-segment, and the right side there is a diffuse pressure losses without any identifiable step up in this curve. This is the angiography, and you see the clinical characteristics in the bottom of the slide, and you will see that there is a clear lesion in the mid-segment of the LAD. We perform PCI. These are the characteristics of the procedure, and after the procedure, we repeated the pullback, and this is what we obtained. A post-PCI FFR of 0.88, but we eliminated that pressure gradient in the mid-segment of the vessel. In the second case, the FFR was also positive, 0.78. And there is also a severe lesion angiographically in the mid-segment of the vessel. So the operator decided to treat that lesion in the mid-segment of the LAD. He got a very good angiographic result, but when you look at the pullback curve after PCI, it appears to be similar to the pre-PCI with an FFR of 0.8. So we indeed did not improve epicardial conductance, and we did not solve any focal pressure gradient. We have described this in the paper in JAG, what we call the description of the functional pattern of coronary artery disease, and we have identified that there are three patterns: diffuse, focal, and a combination of these two types, which we call mixed or combined. Why is this important again? And this is just to make a summary of what we have discussed, is because when you have focal functional disease, again, look at a pullback, this is how the lesion would look. If you look at a model, you get a very nice result after PCI with almost 1 of FFR after you perform your procedure. But when you do PCI in diffuse disease, you might treat this lesion with a stent, but there are residual pressure losses in the vessel that actually do not improve completely or only partially epicardial conductance. So we have described a metric, and this is a very important step forward for the field of FFR, the introduction of the PPG. PPG stands for pullback pressure gradients, and this is a metric that depicts the functional pattern of coronary artery disease. The lower the PPG, the more diffuse the coronary artery disease. The higher the PPG, the more focal the coronary artery disease. So the next step was to understand what happens if you do PCI in patients with low PPG or focal or diffuse disease, and what happened after PCI in cases of focal disease. And you see in the left side of your screen a plot that has in the y-axis FFR post-PCI. And you immediately see the higher the PPG, the higher the post-PCI FFR, and the lower the PPG, the lower the post-PCI FFR. In other words, if you do PCI in diffuse disease, there is a low post-PCI FFR, and if you do PCI in focal disease, you obtain high post-PCI FFR. When we look now at the right side of your screen, and you see that there appears to be a threshold where the PPG is started to identify better the increase in functional conductance and functional gain, Functional gain is defined as FFR post-PCI minus FFR pre-PCI, and you will see that after a PPG of 0.6, there is a huge increase in epicardial conductance with normalization of the FFR values. We have been talking in the last minutes about the epicardial compartment, but we cannot forget that the most part of the coronary circulation is actually the microvasculature. This comprises approximately 95% of the coronary circulation. There are a few metrics that we're working on the microvascular disease as well. You will see here in this slide the term MRR. We will discuss that in a bit. Oops, that was too fast. And here's the first metric, which is actually the IMR, or the index of microvascular resistance. This is an index described by Dr. Dubreuil and then by Dr. Fearon, showing that when this value is very high, it means that you have a high microvascular resistance, and when the IMR is low, you have low microvascular resistance, and the cutoff is around 25. If you measure your IMR, in other words, if you assess your microcirculation, for example, after acute myocardial infarctions, you will see that patients with high resistance have worse prognosis compared to patients with normal microvascular resistance. And this is also a tool that helps us to understand the pathology in patients with chest pain and normal coronary arteries to assess the microcirculation in a more stable fashion. And if we move now not to bolus thermodilution of IMR, but in the next generation of thermodilution derived metrics, that is the continuous thermodilution, we can have this type of tracings, and I'm going to show you very quickly. In the top of your screen, you will see the pressures. This is aortic pressure, this is coronary pressure, but what we see in the bottom is actually temperature. And this is how the temperature decreases after the infusion of 10 milliliters of saline per minute. And this is what happened when you increase your flow at 20 millimeters per minute, you get a reduction in temperature. Actually, using thermodilution-derived theory, we're able to calculate the absolute flow and therefore absolute resistance in the coronary vessels using continuous thermodilution. And then we can calculate what we call the MRR. That is a concept that is similar to the concept of CFR. And you can look at this new concept as how many times your microvascular resistance is able to decrease in order to accommodate higher flow in your epicardial and myocardium. And this is the way that is calculated. I don't have time to go in details on this, but in this case, for example, the MRR was 4.2, CFR, pointing at the fact that the microcirculation is normal. CFR is also normal, 2.8, but a very severe problem at the level of the epicardial vessel depicted by an FFR of 0.66. So we have looked at the two compartments, and with that, I would like to finish the presentation. Not without thanking my friends, colleagues, and my mentors that have helped me throughout my career. Thank you very much.
Thank you, Dr. Carlos, for your impressive presentation. And I would like to ask you two questions. My first question is, if you have all these tools at your disposal, what would you use? Thank you.
Thank you for the question. So now what we are moving towards more and more is to start by identifying if a patient has a coronary stenosis at the epicardial level, to do fractional flow reserve. That is the metric with the most robust evidence behind it. And if the fractional flow reserve is below, let's say, 0.8, that is the cutoff, we then perform a pullback, an intracoronary pressure pullback, to calculate the PPG. If the PPG is high, this patient goes to revascularization with PCI. If the PPG is low, then we have to better discuss with the patient to decide whether he or she can be treated by medical therapy alone, or maybe in some cases, surgery is an option. But certainly doing PCIs in cases of diffuse functional disease is something that we will avoid in the future.
Thank you, doctor, for your answering. My second question is, how can shear stress can help us in decision making? Thank you.
Well, that's a very good question. And until now, shear stress has been a tool that required engineers to work with us. In the first simulations that we did in our group a few years ago, each simulation took about 4 or 5 hours. So that was something that was not practical for clinical decision making. However, I show you in the slides the new prototype that is able to calculate shear stress from angiographic images. That means that you can, for the first time, move your shear stress analysis from the engineering lab to the cath lab, and then use the shear stress to help you in the decision making. How do I see shear stress actually helping us? And that is a question that requires, of course, further studies. But I think that there are some lesions that might be not functional significant based on the FFR cutoff of 0.8, but indeed have high wall shear stress, high TSVI, which are two shear stress derived parameters, and a huge pressure gradient in that lesions. And in our opinion, these lesions could be prone to rupture. The holy grail would be to have shear stress, pressure gradients, and plaque phenotyping, helping us to decide whether this lesion could be a vulnerable plaque, yes or no, and based on that, decide whether the patient needs a more aggressive therapy or not.
Thank you so much, doctor.